Hello, everyone, and welcome to today's webinar. My name is Kristen Reed, and I am a research coordinator here at Health Evidence. We are very pleased that you were able to join us today to talk about vitamin A supplementation for preventing morbidity and mortality in children. I will be introducing in a few moments our presenter, Dr. Imdad, who we are thrilled to have joining us today to present the findings of his recent Cochrane systematic review. We would like to take this time to wish a warm welcome to our presenter today, and also a welcome to all of our health evidence users that have joined us for this webinar. So just to let you know that we will be posting polling questions throughout the session today on the WebEx platform, and your participation in these polling questions is voluntary and anonymous. So I will just take a few moments and leave this consent slide up, and then move on shortly to give you a chance to read it. Okay, moving on. So just to let everyone know that after today, the PowerPoint presentation and the audio recording will be made available on Health Evidence's YouTube and SlideShare accounts, usually within the next week or so. And the links to both of those resources will be posted in the chat section so that you can access them. So today we are very excited to be talking about the review of vitamin A supplementation for preventing morbidity and mortality in children from 6 months to 5 years of age. The link to the Health Evidence Review page for this systematic review will be posted in the chat section. So you can click on this link and follow along in the review using the article full text or PubMed link out. And there is also a Cochrane plain language summary that is available for this review through that record page as well. We'll be posting the direct links to that and the full text article in the chat box. So just a few housekeeping items before we begin. Please use the chat section in WebEx to post your questions and comments. We ask that you send your questions and comments to all participants and not just to the host or panelists. Also, please feel free to post your questions and comments throughout the session. Towards the end of the session, we'll try to save some time for the presenter to respond to any questions or comments you might have, and I'll be reading them aloud to our presenter. For the best connection, we do recommend that you use a wired internet connection versus a wireless. And should you have any connection issues throughout the webinar, we have posted the 24/7 WebEx helpline on this slide, as well as in the chat section. For your audio today, please listen through your speakers. If you are having trouble hearing or there's any feedback, you can go to Communicate at the top bar in the WebEx page, and then click Audio Broadcast. So we have our first polling question today, and we're wondering, and sorry, this can be found on the right-hand side of the WebEx platform, so it should pop up right here. And really, we're just wondering how many people are joining us today, and if you're joining by yourself, in a small group, or in a larger group. So can you please, if you're able to answer the question and press submit at the bottom after you've selected your response. Okay, great. So it does look like most people are joining us on their own today, but we do have a couple small groups as well, so that's great. That's great to see. We would also like to give a special thanks to our health evidence team who have worked to bring this session to you today. There is a large team of us who work to keep health evidence current and maintained, as well as to coordinate this monthly webinar series. For those of you who may not be familiar with health evidence, we are a service and research organization involved in knowledge translation for public health professionals that was launched in 2005. Our main product is a comprehensive registry of reviews where we provide over 4,800 quality-rated systematic reviews evaluating the effectiveness of public health and health promotion interventions. The main goals of health evidence are to make evidence relevant to public health more accessible and make it easier for professionals to use evidence in decision-making. So the value add for using health evidence is that we save you time. We've done the work to screen and appraise each review within our registry. We screen all reviews for relevance to public health and keep our repository up to date by constantly screening relevant databases. At any given time, we are no more than 1 to 2 months behind the publication date. So we have done the work for you by critically appraising all reviews through a transparent process whereby you can actually click on the full quality assessment for each review and see our rating for each of our 10 assessment criteria. The Health Evidence website also has various tools and supports for evidence-informed decision-making available online, and many users have informed us that our tools in repository are both easy and simple to use. So I'm just going to quickly touch on the model for evidence-informed decision-making, which we can hopefully keep in mind as the presenter goes through the systematic review today. This model consists of 5 components that you can see here in this diagram. Traditionally, public health practitioners and decision-makers consider evidence about community health issues in local context, existing resources, and community and political climate in making decisions about programs and policies. However, it's become apparent that considering research evidence can be challenging to integrate into public health practice. As such, this health evidence webinar series is designed to highlight research evidence relevant to public health decisions. On this next slide, we can see the stages of evidence-informed public health that illustrates the steps involved in evidence-informed practice. The wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence into the decision-making process. So as you can see here, there are 7 steps outlined, and today we will be focusing on how our presenter has worked through the first 4 of these steps in order to help public health decision makers with the remainder of the steps in this process. So we do have our second polling question here today. And we're wondering how many participants that are joining us today have heard of or are familiar with PICO or PICOS. I guess pretty straightforward, either yes or no. And it looks like, I guess, the majority of people have heard of PICOS before, but there are a few that are unfamiliar. So as I move on, for those of you who aren't familiar, PICOS is a way for you to structure your research questions. It involves defining who the population is that you are interested in, what the intervention, program, or service is that you want to know about, the comparison group, if there is any, and outlining the specific outcomes you are looking for. Sometimes we also have a particular setting in mind, which we can also state in this format. So, for example, a school or community setting. The value of a PICO question is that when you have an issue that arises, you can use PICO to turn this into a searchable question, which allows you to further articulate specific components of the question and can then help you search for relevant information related to your PICO more easily and efficiently. So moving on to our next polling question before we pass it over to our presenter. And really we're wondering, in your own practice, how often do you use systematic reviews to inform your programs or services? So whether that's always, often, sometimes, or never, or perhaps you're not really sure what a systematic review is. So as people are answering that, I will just maybe give a little bit of a reminder to click Submit at the bottom once you've finished your selection, so that we can make sure that it's recorded. So overall, I think people are mostly in the sometimes camp of using systematic reviews. We have a few in the always, everybody here that's been answering our polling questions so far has heard of systematic reviews. That's really great to see. So with that final question, I will move on to introducing our presenter. We are really excited to have Dr. Imdad with us today to present the findings from this recent systematic review. Dr. Aamer Imdad is an assistant professor of pediatrics at the SUNY Upstate Medical University in New York. And so thank you very much for joining us today. And with that, I will pass the ball along to you.
Thank you, Kristen. Thank you so much for giving me an opportunity to share our work. Before we start, I just wanted to give a brief history of this work. We first published this Cochrane review in 2010 with a sister publication in BMJ. We completed a recent update of the same review, and today's presentation will be based on findings from the most recent version. This review primarily focused on vitamin A supplementation in children 6 months to 5 years of age. Our group also has published separate reviews for neonates and infants 1 to 6 months old, and some of the references are available on this page. So let's start. I'm going to briefly review the physiology and epidemiology of vitamin A. So first, what is vitamin A? So it's an essential micronutrient, meaning that our own body cannot synthesize it, and it needs to be ingested from external food sources. It is a subclass of retinoid family of compounds that are fat-soluble compounds. And the normal function of vitamin A includes that it is required for normal function of visual system, maintenance of cell function for growth, epithelial integrity, red blood cell production, immunity, and reproduction. And vitamin A deficiency can lead to multiple signs and symptoms in the body, including xerophthalmia, which is dry eyes or night blindness, which is the most severe consequence in terms of the vision. It increases the susceptibility to infection, can lead to growth failure, and cause anemia, and in severe cases can lead to death. So how common is a vitamin A deficiency? So on this page, I show the estimates from WHO that were published in 2009. And according to WHO, there was 19.1 million pregnant women and about 190 million children less than 5 years of age who were vitamin A deficient in 2005. Vitamin A deficiency is the most common cause of nutritional blindness in children, and about 122 countries have a moderate to severe public health problem of vitamin A deficiency. There's a recent publication in Lancet Global Health where these estimates were re-looked at, and overall the prevalence of vitamin A deficiency is decreasing. However, it is still prevalent in South Asia and Sub-Saharan Africa. So what are the common sources of vitamin A, and why do we really need to supplement vitamin A when there are naturally occurring resources available? So vitamin A can be found naturally in plants or animals. The plant sources are typically in inactive forms called retinoids. Beta-carotene is one of the famous ones that is mostly known and can be found in green leafy vegetables such as spinach, yellow vegetables such as pumpkin, squash, or carrots, or yellow-orange non-citrus fruits such as mangoes, papaya, and apricots. The animal forms in the form of retinol, and retinoic acid are the most active form and can be found in glandular meat, liver, fish liver oils, egg yolk, whole milk dairy products, and human milk. Now, the reason that we need to do the supplementation is there are 3 main reasons for that. So one is the bioavailability. So the plant sources, sometimes the conversion from the inactive form to active form is low, ranging from 6:1 to 26:1 from different plant-based food sources. Also, in developing countries or low and middle-income countries, there is increased burden of infectious diseases that leads to low consumption of food overall and increased losses in certain infectious diseases such as diarrheal diseases. In addition, there is food insecurity, and overall animal food-based source is less available compared to the plant-based sources. So years ago, it was hypothesized that vitamin A supplementation can prevent morbidity, which will be taken as illness, or mortality, which will be taken as death in children. And the objective of our review was to assess the effect of vitamin A supplementation for preventing morbidity and mortality in children aged 6 months to 5 years. In the next 4 slides, I'm going to briefly overgo and the methods that we use. So the study design was a systematic review and meta-analysis. The type of studies that we included was individual and cluster randomized controlled trial. And then the participants were children 6 months to 5 years of age. Intervention was preventive synthetic vitamin A supplementation. This is very important to understand that the supplementation was preventive and not therapeutic, which means that vitamin A was given to children when they were apparently healthy and not sick with infections such as diarrhea or measles. The comparison group included placebo or no intervention. The outcomes, including the primary outcome, was all-cause mortality. The secondary outcomes included cause-specific mortality due to diarrhea, pneumonia, measles, and then the cause-specific morbidity due to diarrhea, pneumonia, measles, night blindness. We also looked at side effects, mainly vomiting and bulging fontanelle, and we also looked at the vitamin A status reported based on serum retinol levels. We did a comprehensive literature search and searched multiple databases with the help of Cochrane editorial unit. This included databases that covered index and non-index publication, ongoing studies from clinicaltrial.gov, and the regional databases, including a registry at WHO. The last date of search was February 2016. The titles from the literature search were 16 by 2 authors, and the data were double abstracted for included studies. We included the risk of bias according to the Cochrane Handbook of Systematic Reviews, and I will give a little bit more details about that in the coming slides. Meta-analysis was performed when data was available from at least 2 studies for an outcome. We used the generic inverse variance method of meta-analysis using the fixed effect models. For the data that was dichotomous, we pooled the studies to obtain a summary risk ratio and reported it with 95% confidence interval. And the way to interpret the summary risk ratio is that if the summary risk ratio is less than 1, then it means that it favors the vitamin A. And if the summary risk ratio is greater than 1, it means that it favors the control. And in order to establish statistical significance, we're going to look at 95 confidence interval. And if the 95% confidence interval included 1, then it means that those results were not statistically significant. And the continuous variables were combined to obtain a standardized mean difference and reported with 95% confidence interval. In this case, depending on the type of outcome, greater than 0 or less than 0 could be in favor or against of vitamin A supplementation. We assess the overall quality based on the grade criteria, and I'll give a little more explanation as we present results. So let's look at what we found as part of the literature. So this is the PRISMA flow diagram. On the left side, it shows the studies that were included in the previous review. So we had about 43 studies included when we published the first version of this review in 2010. The updated search yielded 5,236 titles, and after the duplicates removed and the titles screened, we were left with 54 full-text reports. And 10 of these studies were excluded with the reason given on the right side in the larger box. After the initial screening and data abstraction, 4 new studies were included that led to a total of 47 studies, with 42 studies contributing data to meta-analysis for at least 1 outcome. This slide shows the characteristics of included studies. So most of the studies were conducted in low and middle income countries. The sample size ranged from 35 to 1 million from Delta trial that was conducted in India. And overall, combining all the patients who were randomized in included studies in this review, the number ranged to about 1,223,856. The dose ranged in included studies from 50,000 international units to 200,000 international units. One of the study used weekly dose of 300 and 866 international units. Retinol palmitate was the most commonly used compound in the included studies. Most of the studies lasted about 1 year or less, and about 11 studies last for 5 years. On this slide, I'm going to talk about risk of bias in included studies. So starting from the right side, the rows shows the different categories of risk of bias that are assessed according to the Cochrane Handbook of Systematic Reviews. It includes the sequence generation, meaning how the randomization was done and was it adequate. And the second is the allocation concealment, that once the sequence was generated, was it concealed at a point where it was not available to either study participants or outcome assessors. Blinding is further divided into blinding of the participants, providers, and outcome assessors. And the next three are incomplete data reporting, selective reporting, and other risk of bias. The dots, the green dot shows that a particular study was at a low risk of bias for that particular element. The red dot means that that study was at a higher risk of that element, and the yellow means that the risk of bias was unclear. So overall, most of the studies had adequate description of their methods, and we assessed them to be low risk of bias. There were a few studies where the blinding was not done, or the sequence generation and allocation concealment was not adequately described. This slide shows the forest plot, and I'm going to show multiple of the forest plots. So I'm going to just go over the anatomy of the forest plots to make us understand the rest of the slides. So starting from the top row, it tells the different titles for the columns. So on the most left side is the study or subgroup that contributed the data. The next two columns are the raw data, and in this case, we use generic inverse variance method of meta-analysis, and the data is inserted in the form of log of risk ratio or standard error. The next column is weight, which indicates that how much of the total weight was taken from that particular study to the overall summary estimate. The next is the risk ratio from the individual studies, and then followed by a column of the year of publication of study. On the most right side is the forest plot in the graphical form, and it shows the summary estimate at the end. The individual studies are indicated with a red dot and a line that shows the confidence interval. Apparently, this graphical presentation is the summary presentation of the data in numbers. The summary estimate is given at the end, and the way we're going to interpret this is I'm going to describe the relative risk reduction, which means that if the summary estimate is less than 1, then we're going to say how much of the reduction in a particular outcome was achieved with vitamin A supplementation. So in this particular case, we'll say that there was 12% reduction, meaning 1 minus 0.88 will lead to a 12% reduction in the favor of vitamin A. One more thing that is part of forest plot is the heterogeneity, and there is one number that we're going to specifically mention in most of the slides, and that is the I-square, which describes the unexplained heterogeneity in the pooled analysis. So let's go over on this particular forest plot. This forest plot describes the all-cause mortality, and 19 studies reported the data. The summary estimate showed that vitamin A supplementation reduces all-cause mortality by 12%, and these results were statistically significant. Overall, there was substantial amount of heterogeneity in the pooled data, and that amounted to 61%. This slide shows the diarrhea mortality in kids who were supplemented with vitamin A and compared with control. This forest plot included 9 studies, and the summary estimate showed that vitamin A reduced the diarrhea-related mortality by 12%, and these results were statistically significant as well. This forest plot shows the pooled estimate for reduction in measles mortality, and vitamin A supplementation reduced measles mortality by 12%. However, the confidence interval included 1, so we conclude that these results were not statistically significant. This slide shows the mortality due to lower respiratory tract infection, that is the abbreviation for LRTI, and it shows that there was no major difference in reduction in LRTI or lower respiratory tract infection related mortality in kids who were supplemented vitamin A versus control. And also the confidence interval included 1, so these results were not statistically significant. This slide shows the diarrhea incidence, and the overall pooled summary estimate showed that vitamin A supplementation reduces illness due to diarrhea by 15%, and there was and these results were statistically significant. There was substantial heterogeneity in the pooled data with the I-square of 94%. This forest plot shows the data for measles incidence, and the pool estimate showed that vitamin A supplementation reduces measles incidence by 50%, and these results were statistically significant. There was no appreciable heterogeneity, and the I-square was 0%. This slide shows the illness due to lower respiratory tract infection, and the pooled results show that there was almost no difference between the kids who received vitamin A versus control. And the summary estimate was 0.99, and the confidence interval included 1, so these results were not statistically significant. This slide shows the prevalence of Bitot spots, which is one of the eye findings in kids who have vitamin A deficiency. So the supplementation with vitamin A reduced the prevalence of Bitot prevalence by about 68%, and these results were statistically significant. So it's 58%. The night blindness was also reduced with vitamin A supplementation with a relative risk of 0.32 that would translate into a 68% reduction. And these results were statistically significant. Only the 2 studies contributed data for night blindness. We also assessed the side effects, including vomiting. So this forest plot shows the data, and there was almost 2-fold increase in risk of vomiting within 48 hours of supplementation of vitamin A. There was also heterogeneity in the pool data with an I-square of 68%. This forest plot shows the vitamin A deficiency, and vitamin A supplementation did reduce the proportion of kids who had vitamin A deficiency with a reduction of about 29% in favor of vitamin A compared to control. This forest plot shows the standardized mean difference, and overall there was increase in the mean serum retinol levels in the favor of vitamin A compared to control. There was also significant statistical heterogeneity in the pool data with I-square of 95%. The next 3 slides, I will describe the summary of finding tables based on the grade criteria. So little introduction to the grade criteria. Grade describes the overall evidence and consider limitations in the study design and implementation of available studies. It takes into account imprecision of results, inconsistency of results, indirectness of the study results, and publication bias. The overall quality of evidence is reported as high, moderate, low, or very low. The high quality evidence means that we are very confident that the true effect lies close to that of the estimate of the effect. The moderate quality describes that we are moderately confident in the effect estimate, and the true effect is likely to be close to the estimate of the effect, but there is a possibility that it is not. The low quality evidence means that our confidence in the effect estimate is limited. The true effect may be substantially different from the estimate of the effect. And the very low quality evidence means that we have very little confidence in the effect estimates, and the true effect is likely to be substantially different from the estimate effect. So the first three rows here shows that the all-cause mortality data that we pulled, our assessment that it was high quality data, and we believe that vitamin A supplementation has significant effect to reduce all-cause mortality in children by 12%. Same was the case for diarrhea reduction. We thought diarrhea-related mortality reduction, and we thought that this evidence was of high quality. The mortality due to measles, the evidence was low, as the summary estimate included 1. The mortality due to LRTI, or the lower respiratory tract infection, the evidence was rated as overall low, and there was no significant reduction in favor of vitamin A supplementation. The diarrhea incidence was also rated as low quality of evidence due to increased heterogeneity in the pooled studies. The measles incidence was shown to be reduced, and we rated this as moderate quality of evidence. The illness due to lower respiratory tract infection was rated as low, and overall there was no major difference in terms of reduction in favor of vitamin A supplementation. We rated the Bitot spot incident as a moderate quality of evidence. And the night blindness was also rated as moderate quality of evidence. Vitamin A deficiency was decreased, and we assessed it to be a moderate level of evidence, and vomiting, which is increased in kids who receive vitamin A supplementation, and we rated it as a moderate quality of evidence. So let's go over some of the strengths and limitations of this meta-analysis. So this study included 47 randomized controlled trials representing about 1,223,856 children. Most of the studies were included from low and middle income countries, and the data is mostly representative of those countries. We used standard methods of Cochrane collaboration, and not only did the quantitative synthesis, but also performed the qualitative synthesis in the form of risk of bias assessment and grade quality assessment. We assessed both the morbidity and mortality outcomes, and the primary analysis for all-cause mortality included 19 trials and overall included 1,202,382 children randomized in this review, and we believe that the all-cause mortality analysis had significant number of studies and participants and represent a strong level of evidence which is rated as high based on grade criteria. One unique thing that was seen with this update was that we included a recent large trial from India called Bitot trial that was primarily a negative study. It changed the summary estimates from 24% that was reported in the last version that we published in 2010 to 12% in the most recent version of this review. But overall, results remain statistically significant. We also repeated the same analysis by using a random effect model, and in that case, the reduction was about 24%. So we believe that even though the addition of large study from India did reduce the overall summary estimate, but we believe that still vitamin A supplementation is shown to have an effect in reducing the childhood mortality. There was a substantial heterogeneity in the pool data, and we did perform some of the subgroup analysis However, we did not have a plain explanation of why there was a variation of effect. We also did not measure the growth outcomes. That might be one of the objectives when we update this review in future. So what are the implications for public health? So based on this review, we believe that vitamin A has a robust effect on prevention of mortality and morbidity in young children. The World Health Organization currently recommends vitamin A for children 6 to 59 months of age in a dose of 100,000 international units for children aged 6 to 12 months and a dose of 200,000 international units for children aged 1 to 5 years every 6 months. We suggested to continue this policy in our discussion, and WHO used the first publication of this review to issue its updated guidelines. And there is another update that is expected soon, and the findings from the most updated version of our review might be used for release of those guidelines from World Health Organization. We, however, acknowledge that the synthetic vitamin A supplementation may not be a long-term solution, and other strategies such as food fortification or food distribution programs and horticulture development should be encouraged to overall increase the availability of vitamin A. So in summary, the take-home message is that vitamin A supplementation in children 6 months to 59 months reduces all-cause and diarrhea-related mortality, and it reduces blindness and illness due to diarrhea and measles. Thank you so much, and I'll take any questions. And before we finish, I just wanted to acknowledge Professor Aamer Imdad, who has been a very kind mentor. He's in hospital for sick kids. At this time, Dr. Herzer, who was one of the students from Johns Hopkins, who has graduated now. Evan, who helped us with data analysis, Dr. Yawul Yakub from Aga Khan University, and then multiple people in Cochrane Developmental, Psychosocial, and Learning Problem Group, including Joe, Chris, Joanne, Margaret, and Geraldine McDonald, who's the chief editor. We also received help from Cochrane main editorial unit, including Toby Losseson, Rachel, and Carla, who helped us with the summary of finding tables. And World Health Organization partially funded the time for this review. Thank you so much.
Thank you so much, Dr. Imdad. That was a really great presentation. It's really interesting to hear about your findings related to vitamin A supplementation and this very robust updated review. So we really appreciate you sharing this walkthrough with us today. Just a reminder to our participants that if you do have any questions, to please post them in the chat box and submit them to all participants. So that everybody can see. There is a couple questions that have come in that I will ask you, Dr. Imdad, if you're amenable to that. So our first question here is, can you comment on the dose or dosing regimens for the interventions that you included in the review compared to what the World Health Organization recommended doses?
Yes, thank you. Most of the studies did actually supplemented according to WHO guidelines, and traditionally WHO has recommended about 50,000 international units for kids who are 1 month to 6 months of age, then 100,000 international units for 6 months to 12 months, and then 200,000 international units for kids who are 1 to 5 years of age. And most of the studies did include high dosages according to WHO and supplemented every 4 to 6 months. There was a trial from India, Ramatullah. They used a weekly dose, and apparently the reduction in mortality was seemingly higher in that. But that was the only study, and there were a couple of more studies that also included a dose that was lower but most of the studies did use the dose according to WHO criteria.
Okay, great. Thank you. Thank you for clarifying that. That's really great. Another question that we have is, do you plan to measure any social determinants in any future updates of the review on this topic? As you suggest that synthetic vitamin A is not a long-term solution, many social determinants such as family income, education could play an important role in the long-term solutions for these types of nutritional problems.
So I think we are actually now doing another exercise to synthesize some of the evidence on micronutrients, including vitamin A, and this is definitely one of the things that is a potential area where we should look at. The subgroup analysis that we performed, we did look at some of the things there were, the data was in a way that we did not have all the data that is reported. So all the studies that reported all-cause mortality did not report the data for subgroup analysis. And I had a couple of more slides. If you don't mind, I can share those. And this is a forest plot based on the age. And what you see is that, so first is that the number of studies are not as many as, say, in the primary analysis that included 19 studies. But overall, there was no major difference when supplementation was for younger kids, like between 6 months to 12 months, or the older kids between 1 to 5 years. The results do remain statistically significant, but we thought that the amount of reduction was fairly similar. We also looked at the gender as well, and also we feel like that even though the effect is probably a little less in boys than girls, but these, again, forest plots were not that conclusive that we can say that it works better for, say, male versus female. And I think the rest of the factors, it's definitely one of the things that we might be thinking when, as I said earlier, we're going to be synthesizing some of the evidence related to nutrition interventions, and that is a potential avenue we might look in the future.
Thanks. That's really great. That's very interesting. I think we'll all be very interested to see what types of perhaps factors that you decide to look like or are able to look at given what research is out there. I guess a bit of a follow-up question to that's a little bit related is you did mention that synthetic vitamin A supplementation is more of a short-term solution, and I think our previous commenter mentioned that as well. Do you have any thoughts or comments on or knowledge of whether it's been looked into the potential of those other kind of longer-term programs or interventions?
There is some ongoing research, and I don't know if you can take Dr. Bhutta online as well, and he might have more comments related to this. But I know there are food fortification programs, and there are also some encouragement in the horticulture and with the crops that have more vitamin A component to it. So overall, the effort is to ultimately, have enough resources available naturally from the typical food resources, and even though the intervention seems simple, like you give capsule or tablets every 6 months, but in terms of program implementation, it still translates into a whole lot in terms of when and the production and the delivery and making sure that the compound is active and then ultimately delivered. So there has been efforts going on in terms of improving the bioavailability in certain foods that has more vitamin A, and that is something that probably is going to come more in the future.
Thank you for your response. That's very interesting. So I think there is just one or two more questions, and then we'll move on to a few polling questions that I actually would like to ask at the end of this presentation. But we do have a question here that is asking, how would you suggest, or I think you mentioned that vitamin A supplementation is recommended for at-risk groups. How would you maybe identify what those at-risk groups are, or how did you classify children that are at risk for vitamin A deficiency?
Yes. So the WHO uses different criteria. So there are some clinical markers that can describe the vitamin A deficiency, including the xerophthalmia, which is the dry eyes, the Bitot spots, prevalence of night blindness, and when we read the report from WHO, they did report the data based on the clinical outcomes, and also the second one is the serum retinol levels, which can also be used to indicate the vitamin A deficiency. Clinical signs are actually more specific for vitamin A deficiency compared to serum retinol, but you can use, say, both biochemical markers or clinical signs to define the prevalence of vitamin A deficiency, and in that case, you will define the kids who are at risk, and then based on that, you can design the program and do the delivery of vitamin A.
Right. Okay. Great. Yeah, that's awesome. And then I think one final question that we'd like to ask today, and perhaps a good one to end off with as well. But I do encourage people to continue adding questions as I move on as well. And if we have some time, we can try to get to them. But given that there is a lot of research on this topic, and for some of these outcomes, at least a very high level of evidence, what type of research studies would you recommend are a priority in this area in the future?
Yeah, so one kind of summary statement that we mentioned in our discussions and conclusions in the full text of this review was that we feel like that the vitamin A supplementation is biologically plausible in terms of its effect for reduction of both illness and death in children. But in terms of what might be the best mode of delivery, including synthetic versus say fortification, or what would be the perfect dose, and what would be the perfect frequency, I think those, and what are the different delivery models. WHO has assessed, giving vitamin A supplementation at the time of vaccinations. So I think those areas are still out there, and we think that designing a placebo-controlled trial in a low or middle-income country where kids are at risk of vitamin A deficiency we think is unethical, and there should not be more placebo-controlled trial to prove the efficacy of vitamin A. But in terms of looking at the mode and delivery of the intervention, dose of the intervention, I think those areas are still open, and there's more information that is needed in terms of what would be the best way to deliver this intervention to the populations at risk.
Very interesting. Yeah, I think there's still a lot of questions, so that's we'll definitely keep an eye out in the future for perhaps some of those answers. So I will move on, and just before we wrap up, there are a few more polling questions that I'd like to ask today. Really, we'd just like to know whether or not the information that was presented today was useful to you and to the work that you do. So if you could please answer on strongly agree, neutral, disagree, or strongly disagree. And just a reminder to please make sure to press the submit button once you have selected your response. So thank you for answering that. And while we leave that open, I will just at this point like to share a few options for ways that you can interact with review level evidence and specifically health evidence moving forward. And these include visiting our website, registering to receive our monthly tailored registry updates, and or our monthly newsletter that went out yesterday. Tell your colleagues about health evidence. You can also follow us on Twitter using the @healthevidence handle. And we encourage your organization to use health evidence to search for review level evidence to inform your program planning and policy decisions. And finally, please feel free to contact us if you have any suggestions for future topics of a webinar or to provide feedback on this series. So with that in mind, and we would really like to get your thoughts on what are your next steps after learning about the review level research on vitamin A supplementation in children. So do you plan to access the full text of the systematic review that Dr. Imdad just mentioned, access the quality assessment for the review on healthevidence.org, consider using the evidence in your practice, or tell a colleague about what you've learned today. So we'll just keep that open for a little bit to finish up, and thank you again for answering all of these questions. We do see that quite a few people are hoping to access the full systematic review, and hopefully we'll be able to maybe post the link to that in our chat box so you can easily access. So thank you again. I don't see any other questions that have come up in the chat, so I will at this point let you know that this brings us to the end of our question period and close to the end of our time. And I just wanted to take a moment to give a very big thank you to our presenter as well as to our audience today for posting questions and making this a very engaging and stimulating session. So thank you very much, Dr. Imdad, for joining us today and sharing all of your learnings. One final reminder that the copy of the recording and the PowerPoint presentation will be posted online in the next week or so. So if you're interested, please keep an eye out for that. So thank you, everyone, for coming. And Dr. Imdad, I will pass it back to you if you have any final words.
Thank you so much for giving me the opportunity to share these findings. And, I'll be happy to, answer any further questions if any of the audience are interested to write an email, and, I can share my email that you guys can share with the audience. But we do think that this area is kind of fascinating in terms of having a fairly cost-effective and relatively easy to deliver intervention. It can have such a huge impact, and we look forward for updated guidelines from WHO that hopefully will be issued soon. And we were informed that this most updated version of our Cochrane review will be used to make the basis for some of the recommendations that WHO might issue regarding vitamin A supplementation in young children. So that is really rewarding as a young investigator, and I hope that our team will continue to contribute more evidence in this area that ultimately might affect a great number of kids in developing countries.
That's great. Yes, yeah. That's I think that's very exciting, and we really look forward to hearing more in the future as more information becomes available. So thank you very much, and I would just like to wish everybody a final good afternoon, and another big thank you for joining.